The following podcast is part of a certified educational activity titled Progress in Developing Novel Treatment Options for PTCL, Expert Views on Integrating Innovative Therapeutics into Care. Access the entire activity and complete the post-test at www.peerview.com/KRV. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Anas Yunus from Memorial Sloan Kettering Cancer Center in New York. Welcome to this educational activity on new evidence in the care of peripheral T-cell lymphoma and key concepts in integrating the latest evidence into practice. Joining me in this panel discussion is Dr. Steve Horwitz, also from Memorial Sloan Kettering Cancer Center. Steve, welcome.
Thanks, Anas. Happy to be here.
T-cell lymphoma is not a very common type of cancer, and therefore I think very few oncologists know how to or feel comfortable practicing or treating these patients. We know CHOP and CHOEP and EPOC. How do you prescribe these things to your patients?
Yeah, I think for the systemic T-cell lymphomas, we know that they tend to have a poor prognosis, and too often the results aren't what we like. So standard approaches that are used include combination chemotherapy like CHOP or CHOEP. Some of us, including myself, have a bias towards auto-transplant. So we look at a relatively maximal chemotherapy approach for healthy patients based on some phase 2 data from the Nordic group, based on our own experience, where we give CHOEP, and patients who have complete responses we tend to take to auto-transplant. Even with that maximal approach, in the absence of randomized data, we get about 40-45% of patients long-term in remission, so certainly plenty of room for improvement.
So do you have preference for CHOEP over CHOP over EPOC, or it doesn't matter?
I would say, to be fair, there's no data that clearly points to one or another. In some retrospective studies, CHOEP had a event-free survival benefit, no overall survival benefit. I think maybe with CHOEP you get higher CRs, you do get a little more hematologic toxicity. So at least for us, when we're thinking about consolidating with transplant, we think CR is important and we lean towards CHOEP, but all of those are okay standards.
So your default, if someone comes to you in the clinic today, your default that my plan is to take this patient to transplant, therefore I'll give you CHOEP and then hope that you'll get a response and you go to transplant.
Yeah, I think how we would explain it is the best phase 2 data we have is with aggressive chemotherapy and transplant, and if that patient's appropriate, that would be our recommendation.
And do you require patients to achieve a CR before they go to transplant? And how do you do that?
Yeah. When we've looked, our CR patients do better, and what's been a helpful decider for us is PET scan on an interim basis. So again, just based on practice pattern, if our patients are negative PET scan after 4 cycles, 2 more than auto-transplant, that's where we get our best results. So we kind of use that as a deciding point.
Okay. So now you have a patient who, let's say, get CHOEP transplant and 1 year later relapse. Walk us through what's your plan for this patient in first relapse?
Right. So again, it's a little bit individualized. If we look at our patients who got allo transplant for relapse disease, so if they actually got an allo, they're about 50% progression free at 1-2 years and beyond. So our first question is that our goal, allo? And that for us would be curative intent. Many patients, for various reasons, that's not appropriate therapy, and then we're really looking at sequential mild therapies to manage disease long term, but not curative intent.
Right. So how many drugs are approved in this space for relapsed peripheral T-cell lymphoma?
Right now for relapse, we have 4 approved drugs. We have pralatrexate, romidepsin, and belinostat, which were approved in unselected or all comers. And then, of course, brentuximab vedotin. The approval for relapse disease is in anaplastic large cell lymphoma.
And how do you sequence these things? Do you have preference if you want to use a single agent?
Yeah, we do have some biases. They're not well data supported, but if you kind of squeeze on the data a little bit, it looks like HDAC inhibitors maybe do better either in terms of response or duration for Angio Immunoblastic patients, maybe less so pralatrexate, less active in those diseases. Of course, brentuximab for anaplastic large cell lymphoma, significantly more active, so that's an easier one. I think otherwise we're sort of looking at dose and schedule and side effects, and then we have a strong interest in incorporating clinical trials at that stage also.
So most people feel, one of the reasons why it's complicated or like not easy to treat patients with T-cell lymphoma because of the complicated pathology. You have how many types right now?
Yeah, it's almost 30 in the new WHO.
And then from your experience, and you get a lot of second opinions from different institutions, do we frequently change the diagnosis or this is like now a standardized diagnostic tool that anywhere can get the same diagnosis?
We do change it a lot. If the initial workup is really broad in terms of immunophenotype and kind of deep diving into the pathology, sometimes we'll refine a little bit. Angio Immunoblastic follicular helper T cell, kind of like subtle differences. Sometimes we'll see a workup though that's fairly superficial, just a couple of immunos putting it in the T cell category, and it really hasn't been subtyped properly. And I think in those cases we often.
And does it matter? Let's say if you went from ATIL to NOS, does it matter in choice of therapy or?
Yeah, not that we have good data for. I think when we think about it and we think about stratifying for clinical trials, it does. Most of the drugs have been studied in phase 2 studies with all comers, so it's not that I can say, oh, you definitely do different here versus here.
So for, let's say, diffuse large B-cell lymphoma, everybody quotes like, we cure 50-60%. Yeah. What's the expected cure rate for T-cell lymphoma in general?
Yeah, for patients who would be transplant eligible, probably between 40 and 45%. I think if we look at all comers, it drops down into the 30s. We'll talk about the Echelon 2 data, which may show that a little differently.
It's interesting, a couple of abstracts came up about real-world data from peripheral T-cell lymphoma. I was actually surprised to see one of them, at least, and it was presented at this ASH. Not a lot of patients, about 200, that only 7% ended up having autologous transplant. Does this strike you as this is really real-world, or you think it's biased information, you think?
It's a little bit low, and I think that series was maybe primarily community practice. Some of us at the bigger centers do have this bias towards transplant, which is a bias. But when we've looked at large registry data, there's a big international registry, there's a U.S. registry. It really is about 15 or 20% all comers get transplant. So 7% I think is low, but it's not like 50% in other places are getting it.
And then if you have preference, let's say in someone who's eligible for both auto or allo, is there preference? Which one do you choose if someone has perfect match?
Because our results, if you're in first CR, with auto, you're up around 50%. Even though we have good results with allo, the treatment-related mortality is still 12 to 15%. So usually if we were picking, we would lean towards auto with a good CR. Lack of chemosensitivity, things like that may make us think a little more about allo, but mostly allo we do in relapse. And
a lot of data now about, again, CAR T cells and B-cell malignancies. Is CAR T cells penetrating the T cell field at all? Or?
There's a lot of ideas that aren't yet in the clinic, but there's a number of ideas in the work. CD30 for Hodgkin's, and there's been a few T-cell lymphoma patients treated with CD30 CARs. I think looking at other parts of the T-cell receptor, CD4, CD5, those are more ideas that are making their way, but not there yet.
Okay, good. So what are the most common subtypes of peripheral T-cell lymphomas in practice?
Yeah, most commonly what we see now is the Angio Immunoblastic or follicular helper T-cell. So that's a malignancy of a follicular helper T-cell. That's slightly more common now as that category has been grouped. Otherwise, peripheral T-cell lymphoma unspecified and the various types of anaplastic large cell lymphoma. That's the bulk of what we see. A number of rare subtypes, NK, HTLV1 associated. We see some in New York, but I think most patients in North America are those three other types.
And anaplastic, how frequent, how common the anaplastic?
It's about 20%. 20%. If we look at systemic, there's some cutaneous versions of anaplastic, and of course there's the breast implant associated anaplastic. If you take those out, it's about 20% of the systemic.
And the Angio Immunoblastic would be?
About 35%.
Okay. And then there's a common misconception that anaplastic large cell lymphoma, ALK positive, ALK negative, that there's some link with CD30. Can you explain this? Are they related at all? Or?
Yeah, they have universal CD30 expression and the cells look histologically similar. We think the ALK positive is really driven by the translocation, specifically with the ALK rearrangement. So they sort similarly, but they have different biology.
Okay, very good. So in the next segment, we'll take a look at some of the evidence with the anti-CD30 antibody-drug conjugate, or ADC, as therapy for previously treated and newly diagnosed peripheral T-cell lymphoma subtypes, including studies that have led to recent approval in this setting. Welcome back. I'd like to start with taking a look at some of the pivotal data on the anti-CD30 antibody-drug conjugate, brentuximab vedotin, in the relapsed peripheral T-cell lymphoma setting, before moving on to recent evidence that has established the agent as a treatment option in newly diagnosed peripheral T-cell lymphoma. So Steve, it's been a while since the phase 1 initial first-in-man clinical trial conducted. It's almost maybe 7-8 years now. Yeah. And there was a signal for peripheral T-cell lymphoma, and there was a quick, pivotal trial led to the approval for a single-agent relapse setting. What happened since then in this space?
Right, so since it was approved in ALCL with very high response rates, 86% or so, there's been some other looks in other types of T-cell lymphoma. So we did a phase 2 study, not super large, looking at other types of T-cell lymphoma that enrolled patients with peripheral T-cell lymphoma unspecified and Angio Immunoblastic Tcell lymphoma. They had to have CD30 positivity by local review, but it could be 1%. And the response rate was about 40% in that population, a little higher in AITL than PTCL NOS, so not as high as anaplastic large cell lymphoma, but responses, including a few complete responses.
And any differences in side effects or toxicities from, let's say, the Hodgkin? Is there T-cell lymphoma specific side effect or the same thing?
Yeah, not that we've really seen. I think in the systemic T-cell lymphomas, it's been neuropathy that may accumulate with multiple doses. There was a sense in the cutaneous T-cell lymphomas who tended to be less heavily pretreated, there may have been a little more rash, but otherwise it's really been consistent with Hodgkin's.
But it's got approved for cutaneous T-cell lymphoma, right? And can you walk us through the trial that led to its approval for?
Sure, yeah. So there was some phase 2 studies, one at Stanford, one at MD Anderson, that showed pretty good single-agent activity of brentuximab for mycosis fungoides, and those studies were really regardless of CD30 expression. And that led to a randomized study called the Alcanza study, which randomized patients with CD30 positive cutaneous T-cell lymphoma, mycosis fungoides. It excluded Sézary syndrome. Patients had to have 10% CD30 positivity. And they were randomized to brentuximab vedotin versus methotrexate or bexarotene, a physician's choice. And that study showed higher response rate. The primary endpoint was ORR4, which was a response lasting at least 4 months, and it kind of beat the standards for all those endpoints, so that led to an FDA approval.
And for anaplastic large lymphoma, what's the mileage you can expect from, single agent brentuximab?
Yeah, the response rate is very high. The median PFS is a little over a year. Most of the patients in the pivotal study got consolidated with transplant, though there were about 10% of patients who had long-term remission without transplant. So there's a subset that really have multiple year durations of remission, but a year on average.
So in your practice, so for Hodgkin lymphoma, for example, we know that the median time for best response is about 4 treatments, and if you're in CR, most of us would, give 8 doses and stop, and some people finish to 1 year. What's your practice in anaplastic large lymphoma?
So for relapsed ALCL, if you've not been consolidated, a lot of those patients are young, and if anything, the high-dose therapy data is better for ALCL than the other subtypes. So we would usually treat them to remission, a couple extra doses, then consolidate with transplant. If the plan is not to consolidate, historically we had just used it till we had toxicity and then backed off. I think now we're doing it a little more like you do in Hodgkin's. We'll give till CR a few more doses, and if the plan is to just maintain, see what happens, and then treat again at relapse.
So you can retreat again, right? You can And what's the data about retreatment? Do you know?
It's really anecdotal. It wasn't really part of the studies, and most T-cell lymphoma patients still in the relapse setting have gotten consolidated.
Walk us through the most recent data from ASH, which is the Echelon 2, which is everybody's waiting to hear. Can you describe the trial first?
Sure. So this was a big study for us in T-cell lymphoma. So the background was a phase 1 study combining brentuximab vedotin with CHP, CHOP dropping the vincristine, or giving it sequentially. And the preferred regimen was BV plus CHP. Had 100% response rate, mostly ALCL, small study, but it looked pretty safe. And at 5-year follow-up, a lot of patients, over 50%, were still in remission.
So it's a replacement for vincristine, right? It's a replacement.
Yeah, for T-cell lymphoma, the thought was vincristine was not as active, and we might lose on neuropathy, so it was a replacement.
And no maintenance, just like concurrent with the CHOP with the replacement of vincristine, 6-8 doses, right?
In the phase 1 study, you could either get consolidated, which nobody did out of 26 patients, or you could get an additional 10 doses of brentuximab, and most patients got that.
Okay.
So the Echelon 2 study, which is the big randomized study, took that arm, brentuximab plus CHP, and randomized it against CHOP, over 450 patients worldwide, and that's what was presented at ASH.
So why CHOP was used as the control arm? Many people use CHOEP. Yeah. Is there a reason for that?
Yeah, we use CHOEP. We kind of believe in dose intensity, but there were some large discussions. And again, when we looked back at our registry data, we knew that about 80 to 85% of patients worldwide got CHOP. It's a reasonable standard. The data that CHOEP is better is unclear. There is data that it's more toxic in older patients. So I think as the study was being done, it was felt that CHOP was a very reasonable, fair standard to compare.
And were people allowed to receive autologous transplant if they responded, or?
Yes, particularly since some of the patients in a blinded fashion would be getting CHOP and people have bias towards transplant. You were allowed, you could either pre-specify or you can consolidate your first remission with high-dose therapy and autologous transplant or radiotherapy. And if you were consolidating remission, it wasn't considered an event.
And what fraction of patients ended up having the transplant?
It was a pretty small number. It was 20% overall, so it didn't really move the data.
So what's the results? What's the response rate, PFS, overall survival of the trial?
So when we look at overall, the primary endpoint was PFS, and it really was much better. Hazard ratio of 0.71. The median PFS for brentuximab plus CHP was 48 months compared to 20 months with CHOP, so really more than doubling of the PFS. I should state that 70% of the patients in the study had anaplastic large cell lymphoma. The other 30% had other subtypes of T-cell lymphoma with CD3 expression. That was a regulatory requirement from Europe as a confirmatory study for the phase 2 approval. So that was kind of built into the design, but the majority of patients had ALCL.
So any subset that did not benefit or did benefit the least from this combination?
Yeah, it's hard to tell. The primary endpoint is intent to treat, and overall the study was positive for PFS, and then again we'll talk about positive for overall survival. And the study wasn't powered to look at the other subtypes. When you look at the forest plot for Angio Immunoblastic Tcell lymphoma, the point is to the right on the CHOP side. For overall survival, it's back favoring brentuximab plus CHP. So the intent to treat is positive, and those smaller non-ALCL subsets don't truly stand alone.
So how this now changing your practice? Now someone coming to your practice tomorrow with anaplastic large lymphoma, that's your default now? It's going to get this?
Yeah, we've been using this, and we're already using it. The FDA approval was a pretty broad label for any CD30 expressing peripheral T-cell lymphoma. While the PTCL NOS and Angio Immunoblastic were smaller, previously we're practicing by subset analysis from non-randomized studies. So this is really higher quality data. And I think the idea that there's an overall survival benefit, not just PFS, we know our salvage rates with T-cell lymphoma are not that great, that it's pretty compelling, and it's at least a strong consideration now across the board.
So up till now, most people, again, based on retrospective data, they used to favor CHOEP for the anaplastic large lymphoma, right? Yeah. And this is where the benefit was most. Do you now, how do you have this room for CHOEP again?
I think with this data, with an overall survival benefit, it's BV-CHP. There are some studies going on look at combining BV with a CHOEP-like backbone. You know, I think that's a further study. There may be high-risk patients, and if that looks promising, that may be a future study. But I think right now, with a 30% improvement in overall survival, this would be what we would use, or you'd have a reason not to.
Right. And even with this really impressive improvement in overall survival, your practice would still to take patients to autologous transplant, or it's a case by case? Is this changing your practice? Or?
I think officially we always individualize the decision, though leaning towards transplant. If you look, for instance, at the ALK positive patients, which all had intermediate or high risk, I think there's only 5 events in the BV-CHP arm. We know there's some biologic stratification within anaplastic large cell lymphoma. DUS22 may be good, TP63 may be bad. As some of that data comes out, we may be able to identify a group in the ALCL group that really there's no additional benefit. They're fine. There may be some higher risk patients who we would still do that. And I think that's still for us to learn.
Yeah. There's also news about the use of hypomethylating agents in combination with frontline regimen like CHOP. Can you comment on that?
Yeah, so there's been some, particularly in the Angio Immunoblastic patients, which tend to have high frequency mutations of TET2, DNM, T3A. There's been combinations or single agent activity of 5-azacitidine in some mostly AITL patients, less so than PTCL NOS. So there's been looks at combining that up front with chemotherapy. There's a study from ASH of lenalidomide combined with CHOP, thinking that may be a better Angio Immunoblastic T-cell lymphoma strategy. I think that data is unclear right now, but that subset may be one that will benefit.
And there was also like romidepsin plus CHOP. Where do we stand with this?
So the romidepsin plus CHOP phase 1 is done. The response rates look good. There is some additional toxicity when you add romidepsin, primarily myelosuppression. There's a large randomized study, primarily in Europe, of romidepsin plus CHOP versus CHOP. That study is done, but we don't have any data yet. So hopefully in the next year or so, and then we'll see. You could imagine CD30, we do one thing, angioimmunoblastic, maybe we do something else and get into a more subtype-specific approach.
So Steve, in the Echelon one in Hodgkin lymphoma, there's a lot of discussion about primary prophylaxis with growth factor support, increased incidence of infection, neutropenia, neutropenic fever. Was this an issue with the Echelon 2 at all?
It was less of an issue. So growth factor support was not mandated. When the data was looked at, patients who got primary prophylaxis had less neutropenia, less febrile neutropenia, and that did make its way into the label. So with that regimen is what we do.
So in your practice right now, you would recommend to start with primary prophylaxis growth factor support from cycle 1?
Yeah, we would for BVCHP. The overall rate of febrile neutropenia was about 16%. It was really the same as in the CHOP arm, but it looked like primary prophylaxis reduced that.
And what's your practice now? Someone comes to you with anaplastic large cell lymphoma. You start with the BVCHP, and then they have grade 2, 3 neuropathy. What do you do?
The data is so new that I don't have anyone into cycle 4 yet. I think I have one patient on cycle 3. In the study, if you had grade 2, we held, and I think that's probably what I would still do. I think if you're having a great response, I'm more comfortable backing off, though it is a pretty active drug. If we're going to consolidate with transplant, I'm more comfortable lowering the dose. If we're just trying to get through 6 cycles of treatment and we think that's curative, the tendency would be to try to push on at least with some BV, maybe at a dose reduction.
Excellent. Any other news you'd like to share from ASH on T-cell lymphomas that we didn't discuss?
It was a big ASH for T-cell lymphoma. There was a lot of new data, mostly Echelon 2. I think a couple of abstracts on PI3 kinase inhibition, one from our group. There's some other drugs with PI3 kinase delta gamma inhibitors that look like they have activity. Still trying to sort out who's the best responder for that. A couple of drugs targeting the JAK-STAT pathway, Ruxolitinib, by Alison Moskowitz, one of my colleagues, Sirtullatinib, which is a SIK-JAK inhibitor. Those look like they have activity. So again, those studies show activity across the board. I think the next step will be trying to refine which patients are most likely to benefit, and I think probably those will go forward.
Excellent. Okay. Well, thanks, Steve. It's really very helpful and very insightful about what's happening now in the T-cell lymphoma field. After a really long wait, finally we found something that's improving patient survival. And thank you for joining us today. We hope you've found the activity informative and useful to your practice. Thank you.